All right, welcome, folks. You have people streaming in. All right. Well, welcome. I'm going to go ahead and just make a couple of introductions to begin. My name is Stephen Beeson, and you are here for the very first episode of This Clinical Life. And delighted to take on nurse retention, nurse well-being as our first topic. With Marla Weston. And Marla and I have become colleagues and friends over the past few years. And as the former CEO of the American Nursing Association, she's had this incredible perspective from a frontline nurse to a nurse executive to influencing policy to now working with nurse leaders from across the nation in terms of how she's seeing the current circumstances and what actionable things are beginning to work and what are the levers we can pull to make life better for this critical threat to American healthcare right now, which is the nursing conditions. And just to give you a little background on This Clinical Life, for those of you that I haven't met, I am a family medicine physician and have really dedicated my life to helping clinicians, care team members, leaders to become their best, to really do two things: to massively contribute to better care for the patients that we take care of, and to do our work in a way that allows us to love the clinical life. And knowing among physicians and nurses and APPs and leaders and our frontline staff, for that matter, the clinical life is tough right now. And for us to be able to take care of those that care for others is the most important thing that our industry can do. So really excited to learn. And I'm delighted that you let a physician in on this conversation. So I'm going to be learning right alongside with you. So Marla, how are you? Thanks for joining us.
I'm doing very well, very well.
All right. Well, outstanding. Well, let's get rid of this here and so we can see each other a little bit more clearly. So Marla, give us a little bit of your background. I gave them sort of the highlights, if you will, but tell us your story and how you got here.
Well, I am a registered nurse, and I have been a nurse for a little more than 40 years now. I was sharing with someone that when I started my clinical practice, most of the patients I took care of were having cataract surgery. They came in the night before surgery and they stayed for 3 days post-op. Right. So I have lived through some pretty dramatic changes.
Nice use of medical resources.
Yeah. I also jokingly say that I've done every job that there is as a nurse. I've been a nurse, an educator, a clinical nurse specialist, a hospital nurse executive. I was the CEO for the American Nurses Association for almost a decade. And for the last 4 or 5 years, I've been doing consulting. And it gives me this really interesting perspective. I've been in the field, I've been on the front lines, and there's something about being able to stand on the balcony and watch what's happening that I think I can offer some really hopefully helpful perspectives in what's happening.
Yeah, one of the things, all of us are immensely aware. I mean, it's now on the headlines of newspapers, lay press, regarding the conditions of the American nurse workforce. If you were to provide sort of an S-bar, if you will, of how things are most currently, and I would ask you to think about what you're hearing from executives, what you're hearing from nurse leaders, and what you're hearing from the frontline nurse. And if you had a sort of a composite summary of the most recent thinking of the current state of nursing right now, what would that story be?
Yeah, it would be staffing. And part of what I think people need to understand is that some of the situation we would be in even without the pandemic.
Right.
The fact of the matter is we have 10,000 new patients a day entering Medicare. And I'm not talking about that just as an insurance mechanism, but it reflects the aging of our population.
Right.
At the same time, those nurses are aging out of our healthcare delivery system. So we have a fundamental demographic imbalance in terms of supply and demand that was going to be there no matter what. We also know that even prior to the pandemic, a third of nurses reported that they were burned out. So, the healthcare system and the way that it is designed and the pressures that we're putting on nurses had 1 out of 3 coming to work feeling unengaged. And at the same time, we know both for physicians and nursing colleagues, the burden of the electronic health record, which is sucking a third of nurses' time in the hospital system, and detracting from what they want to be doing, layered on to all of that. It has, if people feel like it has gotten worse because of the pandemic, it has. We lost 100,000 nurses last year. A disproportionate number of those nurses were under the age of 35. Part of that, like for everybody in that age group, has to do with childcare and the pressures around childcare. So all of those forces are really sort of commingling, right, with the pandemic and everything that happened with the pandemic on top of that. So if it feels like it's tough, people are right. This isn't in their imagination. This is legitimately difficult.
So, I think that was a reiteration of what everybody's feeling, seeing, and experiencing, and why they're on this webinar and reading articles and grasping at what are the solutions that might work. Do you believe, based upon what you've seen and the historical precedent of how American healthcare institutes change, that we have an accessible solution that we can execute against?
I think we have a couple of accessible solutions. And, in some ways I want to go, thank you, pandemic, for amplifying the pressures, because that's part of what's motivating the change. But there are a number of accessible solutions. One does have to do with really looking at the processes of how nurses are delivering care, the burden of the electronic health record, and figuring out how to remove those obstacles, those annoyances, those irritations to care delivery. I think every organization, if they don't already have some sort of systematic process to deal with that, really needs to be dealing with that. And when I say systematic process, like some mechanism for nurses to report, people available to act on what they report, and a mechanism of letting nurses know what changes have been made. So, really systematizing that. So I think that's one tool in our toolkit. I think another tool in our toolkit is the innovation that we brought forth and really saw during the pandemic. We've had this myth in healthcare that it takes us a long time to make change. We made a lot of changes happen really quickly during the pandemic. And I think using that momentum, I see a lot of people doing micro tests of change around nurse staffing that they're not sure if it's going to work or not, but at least they're trying something different. And I think that brings some hopefulness to nurses, right? We can talk about what those are, but I think that's definitely it. I think I also see a lot of organizations going back to professional governance and saying, what is professional governance really? How do we have a structure where nurses have a place to have conversations about their practice, their education, their onboarding of their colleagues, a way to learn and grow and stay clinically connected in the organization? And I think organizations that are really investing in having meaningful conversations with nurses, by nurses, with the decisions being made by nurses, really have a leg up.
Right. So I want to think of it, I sort of think about problems in multiple layers, right? I mean, if we say the future state is sufficient staffing, nurses highly engaged in their work, recommending the profession to friends and colleagues and associates, saying, this is an amazing life of purpose, impact, science, and intervention, where I'm highly respected by the community and my workplace, and this is what this profession should be. I mean, let's say that's a future state, right? It's not that right now. That's a good word
I'm
to say,
guessing it's
right?
not, yeah.
So getting to that future state is really multiple layers of interventions, all of which will begin to shift the engagement and the experience of nursing. It really begins with policy, right? I mean, there are policy changes that could institute a restoration of the nurse pay, experience, and other policy changes regarding staffing and support and development and governments. Let's not talk about that. Not because that's not important, because it's super important, but we want to have interventions here for the attendees that are proximal that they can use right now. And
Mhm.
getting involved with policy is, God bless you, go for it. We need strong voices to advocate for the quality of life of nursing, no question. But the next level is organizational,
Right.
right? And you mentioned some of the organizations. If you were to say, and you had mentioned some of them, but as you survey innovations that organizations are doing that are reducing nurse burnout, that are improving retention, and are beginning to move the needle, what are the actions of those organizations as a very best practice that you've seen from your angle?
Mhm. Yeah, I would say one of the best practices, as I already mentioned, is having some structure in place around removing those pebbles and annoyances from people. Now, that can be having some sort of committee structure, or even a 1-800 number that people report problems to, that there's a team of people on the back end who are
Right.
addressing. I think one of the other innovative solutions that I just recently heard about is one of the hospitals created an innovation unit, and it is the place that they test any new changes that are being recommended. And the concept there is nurses who like to be on that leading edge, nurses who like that challenge of changes and are comfortable and enjoy even the ambiguity, are the ones that work out the bugs in the system. And then it gets rolled out to the rest of the organization. And I think there's twofold things that are really nice about that. One is, just having this place to test it out. But secondly, when it does get rolled out, the other nurses in the organization have some confidence that their colleagues have given it their good housekeeping seal of approval. So I think that's one of the things. The second thing is, I think everybody is experimenting with staffing and new models of care delivery,
Mhm.
including using technology and robots or artificial intelligence or something. And I would say, if you're not doing that, once again, think about doing some sort of micro test of change on a unit or a handful of units.
Mhm.
And, that is everything from bringing LPNs into the ICU to do some of the task-based work so that RNs can care for more patients, but focus more on the intellectual work that they need to do in caring for those patients. I also heard the other day about a unit that is using a nurse practitioner RN LPN model of care. We also certainly have seen people bring in virtual nurses. So I think whatever people
Right.
are doing, another, I think, really inventive idea based upon one of the things that happened during the pandemic. During the pandemic, we brought lots of nurses from the perioperative area and ambulatory care centers into acute care. Some of those nurses loved that work. And so one hospital is testing having nurses work 13 weeks on an inpatient unit and 13 weeks either in periop or an ambulatory setting.
Right.
Based upon 13 weeks, because most travel nurses work 13 weeks, they
Right.
don't know if that's the right model, but giving nurses this kind of interesting job where they can work two different practice settings. There are 1,000 logistics to make that work. But the fact that people are trying and testing it and trying
Right.
to figure out if it works. I think back to when I was in the 80s and 90s, we were very creative about staffing. We had weekend only work. We had 9-month work so that women or men who wanted to be home with their school-age children in the summer could be home with their school-age children. So I think tapping into all of that creativity
Right.
is something that we're going to have to do.
One of the things, and there was a chief experience officer that I had a conversation with a couple of days ago that brought this up. He said, and I think it's a great point, we're so in the vortex of we have to get sufficient RNs on med surge tonight that the ability to have space to innovate and rethink how care is delivered is compromised. So we end up just whack-a-mole in terms of trying to fix immediate staff issues that we're not thinking about longer term innovations that could grow the capacity with what is likely to be an ongoing workforce instability issue. How do you balance the vortex of we've just got to get our staffing fixed next shift to how do we build an innovation center and harvest the best practices across the country on true innovations that fuel the quality of nurse experience as well as improved effectiveness of staffing?
Yeah,
How do you
this is
strike
a
that
place,
balance?
yeah, this is a place that I think we get the answer from other industries. Literally every other industry will tell you that a nurse leader cannot do both things simultaneously. Because the fact is you will get sucked into the vortex of the urgent all the time. And you need dedicated people who are concentrating and paying attention on how to redesign the models of care, how to test new things, how to even aggregate what are the possibilities. So one of the things that I would say is by creating some cohort of people and giving them the time and the resources, but mostly the time to concentrate on thinking about this.
Right.
And, I even happened to be at a workshop that a nearby hospital asked me to come speak at last month. And they pulled about 200 nurse leaders. And when I say nurse leaders, I mean people in management positions, but also nurses who were in leadership roles within their professional governance structure. And they spent a day talking about strategizing, planning, and making decisions around what tests of change they were going to do. Wow. And I know it was tough to pull 200 nurses out of that system for that day, but I have to say it was an investment in not only their long-term plan, but people walked out of there charged up. You talk about getting people re-engaged, they were re-engaged.
Yeah, I think the importance of optimism and hope is essential because without hope that we can take action to make things better, then it becomes hopeless, right? And that's a brutal sentiment to have.
Yeah, and I will tell you, I spent some time a couple months ago really studying what it means when you're in a state of despair and how to get out of despair. And hope is the key, but it is hope coupled with action.
Right.
Hope is action. And so, optimism is just sort of like imagining that it's going to get better by all of its stuff. So there's something about once people understand that you have a plan and you are taking action, even though we all know that the plan is going to be imperfect and need to be modified, we're going to go through that whole PDSA cycle a million times. But that's okay. It is all about starting somewhere.
Right. One of the other things that I think is important to think about, so we're thinking about organizational interventions that could advance engagement, retain talent, and fuel the quality of life of the nurse life, right? What about executive sponsorship? There's no executive that doesn't say workforce instability is a critical issue for us, but saying that and sourcing it are sometimes two different things, right? And so for those executives that are on, or those that have immediate proximity and are carrying the bucket of water for sourcing for workforce stability regarding nursing, what's the profile of the executive sponsorship that capacitates the organization to make real change to fuel the engagement of nursing?
Mhm. I think the nurse executive needs to be an evangelist for this, right? They need to talk about it, think about it, carry the water on it, but they also cannot do it all, because their job is to oversee the whole organization, and they have a lot of things that they're responsible for. So it really is having those deputies, if you will. One of the things that was interesting is that our colleagues at Baylor Scott and White, one of the ways that they dealt with really focusing on nurse recruitment is they recognized that they needed somebody who was paying attention to this every day. And they brought back a retired nurse executive to just focus on this for a couple of months and get the infrastructure in place.
Wow.
And the leader there even describes that if she couldn't get this retired nurse executive to come back, she actually would have restructured her team to free somebody up to concentrate on it.
Wow.
Because it is something about having someone come to work every day, and this is what they're paying attention to. So whatever those priorities are, right?
Right.
And that really began to move the needle. And she didn't have to be there for forever, but just enough to get the mechanism hardwired into the organization.
The other thing that I think is important, and then this is just from a physician lens, in terms of what organizational actions can we take to stabilize our critical workforce that provides the majority of healthcare in this country, right? Is the advocacy of the CMO.
Yeah.
We're the greatest of organizations care for their people. And whether it be food services or your hospitalists, your ED physicians, or your nurses, that should be elbow to elbow as advocates and champions for resources to care for your people.
Yeah, I was reading an article this morning in a business journal, and it was talking about, a decade or so ago, it described that every organization was an information organization, basically, right? And in today's day and age, every organization needs to be a well-being for its employees organization. They worded it all more eloquently than I just did, but I think certainly in healthcare, we have learned that we cannot deliver healthcare without keeping our people healthy, right? We need to transform our culture. We need to create whole new systems and processes and assumptions around what it means to be a nurse, what it means to be a physician, and how to help people healthy. I mean, we go to work every day and we see challenging, horrific situations that confront our humanity, and we cannot pretend that people can go home and just slough that off.
Right.
So we need to understand the burden of the work and make sure that we have an infrastructure that supports people doing that work.
Right. And the executive sponsorship, and the space and breadth for innovations, taking time out of the vortex, and an ability and empowerment to be able to take ideas to action with the permission and the safety where something may not work out, but you're empowered as a local leader to be able to take an action with a sponsorship to give it a shot.
Yeah.
So those are some of the organizational band kind of profile. Let's take it down a notch to local teams. And
I didn't get that. Could you try?
But local teams are where really engagement occurs. Engagement's a local phenomenon. It's not the CNO that engages the frontline labor and delivery nurse, or it's the local unit. So what are you seeing as kind of the profile, if you will, of kind of the local manager and the local teams, and how they interact and support each other to fuel engagement and
Mhm.
burnout reduction? I mean,
Yeah.
what are you seeing, and what's your best guidance?
I
on the
mean,
team?
you're hitting on really, I think, a key point. We have known for decades that the nurse manager is really key to
Mhm.
nurse engagement and nurse retention. It is, I have even said this whole entire last year is, if I had any point of intervention, it would really be that nurse manager. If we have a nurse manager who can coach and mentor and support and create psychological safety and meaningful engagement for the nurses within their unit, those are the shining stars. And even right now, if people think about it as they're listening to this, they can probably identify like this, those units where nurse managers are doing what they need to be doing, coaching, mentoring, engaging, involving, and nurses as a result are engaged, turnover is low, satisfaction is high, patient outcomes are better. And across the hall, something different is happening, right? So we know what it looks like. It is really, how do we normalize this and how do we help this? And even, those nurse managers who are not performing well, it's not for lack of intent or desire. There are some behaviors that they have not yet learned that if they learned, they could put into action.
Right.
And those are really all around helping nurses to find meaning in their work.
Right.
Now,
Yeah, go ahead, Marla.
yeah, and I was going to say, one of the things that I often talk about is, the average nurse, when they walk out of their shift, this is what runs through their head. Is it something like, oh my gosh, I didn't do this. Oh, I forgot to do this. Oh, these were all the other things I meant to do. Oh, this, I forgot to do this. I should have done this. They walk out feeling like this burden of all the things that they didn't do. Now, some of that comes legitimately from being a professional. When you are a professional, you have this laundry list of things that you know that you can do. And the reality is, you can never do them all. So what nurses should be saying to themselves at the end of the day is, did I prioritize the most important things? Right. Out of all the things that I needed to do, was I focused on what was going to bring the biggest impact and make the biggest difference for my patient? And that's what they should feel good about. Right. So there's something about changing that conversation that nurses have about their work that's a practical thing that managers can begin to do, that nurses can even begin to do with each other.
Right. We've got some great questions coming in. We're going to start to field some of the questions, and some of the questions that came in before in a few minutes here. It was really interesting. I was at a conference just yesterday, and we were talking about leading to engage, right? I mean, there's a profile of leader where the people that are on that team say, I love who I am here. I'm super proud of our team. We help each other, support each other, lift each other, laugh together, compete with each other. We go on runs together. We're friends. We know each other well. We're a family. And yeah, it's hard as hell, but we're with this unit, with this tribe, we can do anything. Yeah. And a local leader can help facilitate the safety and the local culture of recognizing, valuing, and knowing and trusting each other. But the conversations I had with the senior leaders that were at this conference was, you know what, everything is spilling down to the local leader. We can't ask anything more of them. Yeah. So it was like, really?
Yeah, so, no, I think that's exactly right. And, I want to sort of underline something that you just said, and it is this idea of having a tribe. Right. That's psychological safety, right? I believe that people have my back here. We are in it together. And that is the one sort of baseline element that is essential. You don't get to actualization till you have that safety right. in place. Right. And as you described, people can work hard, people can be challenged. As a matter of fact, some of the best organizations, people feel like this is a challenging place to work. It's hard to work here. but we are a team and we help each other out and we're all in this together. And when you can create that, everything flows from that. Now, I do want to talk about this. I was going to say pinch, but it's more like, I don't know, like mega squeeze that is going
Compression,
on
right.
to our frontline nurse managers. And I'm glad that you mentioned that, because there are a number of organizations that are really doing deep work around the role of the nurse manager, and they are unloading so much of the work that nurse managers historically have done, and bringing on resources to do that kind of work. You don't need a nurse manager to sign off on time cards. We've often, I'm using that as an example. We've often said that the nurse manager needs to do that to see if someone's working a lot of hours. Well, you know what? You can have somebody else sign off on time cards, and if somebody's working a lot of hours, they can let the nurse manager know, right? So really doing a deep dive to say,
Right.
what are nurse managers spending their time on? I think there's also a lot of coaching and mentoring of nurse managers. When I was a nurse manager, we had pagers. The accessibility now of people being able to call and text 24 hours a day, we have to put some boundaries and barriers on that and normalize the expectations. Some of that is nurse managers relinquishing and learning to really delegate and trust their assistant nurse managers or charge nurses or others. But when you have every decision funnel up to the leader, you are going to be overburdened. So I think there's a lot of work to do to really unpack the role of a nurse manager and normalize it, so that they can spend their time on the things that they should be spending their time on.
Right. And the things that advance what we know must happen, which is creating places where people thrive.
Yeah.
And so to talk a little bit about the role of there's some variance around how leaders are leading, right? I mean, there's some that have highly engaged teams and others have teams that are running for the exits. And a lot of that can be the conditions that they're working under and how their leader is leading. What do you see as the role of leadership development at the manager level, knowing that engagement, again, is a local phenomenon? What have you seen as sort of the best practice in that approach?
Well, I would say best practice is really focusing on leadership development with that frontline nurse manager, really offering coaching, mentoring, and how to be a leader,
Right.
down to the level of what are the behaviors that work. So I think that's really
Right.
essential. And, there are lots of mechanisms to do that. What I will say is sending people to a class and then putting them right back into the same system without some sort of ongoing support around how to put this into practice never works. People really need someone to help them translate those concepts that they're learning in the classroom into actual practice.
Right.
So I think that's really just fundamentally essential. I think the second thing that I would just say is, we all experience this. When you're in that negative spiral, it is just so easy to get caught up in the vortex, and it does require somebody from the outside to come in and intervene and help you. I remember once doing some work with a nurse manager whose unit was very short-staffed, and she consistently came in and worked the night shift because she didn't want to leave her night shift short-staffed.
Right.
Well, that's a fabulous short-term solution, and her staff loved her for doing that. But then the fact is, she wasn't there the next day when potential new employees were available for her to interview and hire.
Right.
So helping her to really sort of understand the short-term consequences of not paying attention to the long-term. And there was just no other way of getting her out of that than like literally jerking her out and saying, you absolutely cannot, no matter what, work any more night shifts for the next 3 weeks. It was just like, sometimes you need that kind of intervention. We all need that kind of intervention.
Right. Yeah. A couple of things that I've observed on sort of team-based care. I think that there's one hospital that was providing mentorship incentives for senior nurses to mentor younger nurses. And, the literature on mentor-mentee relationships is that it really radically reduces turnover. It builds a relationship. and both the mentor and the mentee benefit equally.
Mhm.
And they had some financial recognition for it. So it was a bit of an honor and a sought after opportunity. The other
Well,
thing,
and
yeah,
I'll just add to that, Steve, we saw a lot of retired nurses flock to help during the pandemic,
right,
right? From everything to doing COVID tests to showing up and serving food, right? Whatever things.
right,
So you don't have to pull someone from inside the organization to do that, but really pulling out your virtual Rolodex, so to speak, and calling people who've worked in the organization and maybe retired over the last 3 to 5 years. Because they may not be interested in working full time. They're not interested in working full time, but they may be willing to work 1 day a week and coach and mentor someone.
right.
And so really being creative about where those resources are.
Right. No, and we now know that many of the nurses that are leaving, despite many being under 35, some are leaving with 20, 30, 40 years of experience. And the difference between a new nurse and a seasoned nurse, I can speak from a physician standpoint, there are nurses that I go to that say, what do you think we should do next? Because
Right.
they've understood just the nuance of clinical assessment so well
Mhm.
that you just don't have that a year or two out of nursing school. And
Right.
having that accelerant through a mentor-mentee relationship can be an idea of a innovation that could
Mhm.
be one of the dials that we turn to advance the engagement and support of our nursing staff. The other issue that I think is really important, and I just read an article a couple of days ago on what executive leader empowerment does to the local leader manager, meaning I mentioned this before, but passing power to the local leader to allow them to innovate and create and even define their own local team culture. Because you can't tell a team what they're going to do, but the
Mhm.
local manager is saying, what kind of team are we going to be? And who are we going to be for each other? And allow them to craft their own future as opposed to, oh yeah, there's our mission. I guess we have to take that and tell our people to go be that,
Mhm.
as opposed to this self-determination identity of who do we want to become as a team, and
Mhm.
allow people to craft that story to say, this is the kind of team I want to be a part of,
Yeah. Yeah.
and they have a voice in it. They have a voice and autonomy and volition.
Yeah.
Uh,
And you can
they're-
imagine a unit where the nurse leader has that kind of a discussion with the staff through staff meetings. What kind of unit do we want to be? What kind of unit do you want to be? What kind of
right,
practice do you want to have? What kind of team do you want to have?
right,
What kind of team do you want to be? And then, really generates a conversation. And then what does that look like? Right? What does
right.
that look like in real life? It's interesting because we sometimes toss around words like we want to be respectful. Well, what does respect look like? I
Mhm.
did work with a unit once about what was respect, and somebody described when you take the last cup from the coffee pot, you make a new pot. That's respect.
You bet. Yep.
So, maybe not everybody would say that, but when you get down to those sorts of behaviors and make a peer-to-peer commitment
Right.
that that's what we're going to do, then that changes everything. Because if you're the person who said that, and the next time you go to get a cup of coffee and there's a whole new pot there, that's going to feel really good.
It's an incredible signal. And what's interesting is when we're in the vortex of we have to get sufficient RNs on med surge tonight, you know, we're much more likely to go command and control.
Mhm.
We're much more likely to go top down. And having worked with clinicians for over 20 years now, they won't do it because you told them, even if it's a good idea. And the idea of empowering people to craft their future and who they aspire to become, first of all, they're going to aim higher than you, and they're going to own it and become champions for it and super prideful about it.
Mhm.
And that's where innovation comes from. So, that great book, Multipliers by Liz Wiseman, about how to be a leader that multiplies the impact of others, is about, empowering local leaders to create and innovate. So before we dive into some of the questions, so we talked a little bit about what teams can do. And I think the theme is, allowing them, developing local leader managers. I think it's engaging in leader behaviors that we that are proven to engage those that they lead, empowering local leaders to be able to craft and tap the ideas of their team, and some of the other elements to create these high performing units and tribes and families to create really durability and what is it's a hard clinical life even under the best of circumstances. So let's talk a little bit about what the individual can do. We talked about organizational interventions, team interventions, and now the individual nurse. What are you seeing as the evidence of things that individuals can do to help find joy and contentment and a sense of accomplishment in this work? And you're not allowed to say yoga.
Yeah. Can I just say, yeah, enough with the yoga. And as you know, I love yoga, but enough with the yoga. The key here really is to recognize and help people get back to why they are doing this work. And when I talk to nurses about why they are doing this work, it really comes down to three fundamental reasons. One is they want to make a meaningful difference in the world. They want to make a difference in people's lives. Number two, they went into nursing because of the intellectual stimulation. It's a place where you can make a meaningful difference in people's lives. It uses science, math, technology, the complexity of human beings and figuring out their problems and what the solutions are, and no two patients are ever exactly the same. There's this intellectual challenge to all of that. And three is that it is a human connection. It is the social connectedness, right? Those are the really three things that people want when they go into nursing, are looking for in their work when they do nursing every day. And so helping people re-tap into their why. One of the workshops I do is about rediscovering your why. And it's having people go back to that moment when they decided to be a nurse, and what is that? And where are they seeing that and finding that in their practice every single day?
Right.
And so, even saying to people, when was the last time you experienced that, right? And what are the barriers that we can remove to take you away, that take you away from accomplishing that, right? That's the crux of all of it.
Right.
I do think that I mentioned earlier, we need to do some really substantive work around well-being. And, I jokingly say enough with the yoga. But I think what we also need to understand is that every nurse needs a way to go home and disengage. It's not about the yoga or the bubble bath. It is about being able to go home and leave work at work, right? So whatever that thing is, and part of what I say when I say leave work at work, I'm talking about the whole of your work, and taking care of the kids and taking care of your mother-in-law and being the Girl Scout troop leader, the whole, leaving all that work. You need a place that you absolutely disengage from that, and making sure that people understand that they deserve that in their life.
Yeah. Those are such important things. And I think that some of the things, it's almost like remembering what our identity is for ourselves and who do we want to be in this life. And when I work with clinicians, the process of developing physicians is tell me what kind of physician you want to become and what kind of life you want to have. And despite the fact that they have all diverse answers, there's incredibly consistent themes. They want to be a healer and a difference maker.
Yeah.
They want to be a trusted colleague. And they want to find joy and contentment and balance in their lives. And once they form that identity, then it's a matter of self-reflection, saying, am I living my life in accordance with those things? And usually it's radically different. I'm caring for myself and promoting my own my own wellness. I'm spending time with my kids and my family. I'm being the kind of nurse that I've always wanted to be, or physician I wanted to be for the patients that I take care of. I'm being a great friend and colleague
Mhm.
with my clinical teammates, and I go, God dang, I'm not.
Yeah.
And
Well,
that
and I think
dissonance, yeah,
sometimes, yeah, and then I think the next level of that is, what is preventing that from happening?
right,
And what part of that is within your own control?
right,
Because, we are, as nurses, we go into this profession because we want to make a difference in people's lives. We have a very natural tendency to be helpful. That has our dopamine and serotonin receptors fire every time we're helpful, right? We're doing what we wanted
right,
to do. And yet, we also know that once you do that too much and you feel like you're not being treated fairly, it becomes a real negative and you begin to get resentful.
right,
So I often tell nurses, watch for that little nugget of resentfulness. That is a marker to you that you need to be saying no.
right,
Because if you can stay on the right side of that, then you don't deteriorate into burnout, right? You get to have this meaningful life where you make a difference in the world. And we are enculturated within the profession. I will say we have historically been enculturated within the profession to self-sacrifice to the point that we compromise our own well-being. That was our norm. And I say that was our norm. And once again, thank you, coronavirus,
right,
because I think that when I talk to my colleagues who are under the age of 25, they no longer have that assumption. And they are going to lead the way for us around how to have this kind of practice where we make a meaningful difference in the world without sacrificing ourselves, right?
yeah,
And that is when we operate in the space of joy and contentment and teamwork and well-being and get all of the benefits that we want out of the practice for ourselves and
yeah,
also in making a difference in the world.
right. And I would even say, and this is a thesis, that nurses and physicians' ability to sacrifice self for the benefit of patient has allowed executive teams, not maliciously, but executive teams, to kick the can down the road in caring for their care teams, because we
Yeah.
soldier on, and you eventually you run out and threaten American healthcare delivery, which is where we are right now. So
Yeah.
anyway,
Yeah.
yeah. So we've got some great comments coming in.
Okay.
But let's field. There's a couple of questions, Marla. You had a chance to review them, and there are certainly themes. What are the ones that struck you in regards to all the questions that came in advance, and then we can Lauren and Jenny and Denise, we've got Heidi, you've got some great comments in the comment section, and feel free to drop additional questions in there now, and we'll take the last few minutes to field some questions.
Yeah, a lot of the questions were about things that we've already talked about, retaining nurses, improving nurse satisfaction, wellness, organizational connectedness, moving to actively preventing burnout rather than reacting to burnout. So I think we've covered a lot of this. One of the other questions, though, was about professional development, moving medical assistants to LPNs, to RNs, to BSNs. And I think a lot of people are looking at those programs, how to grow your own. I think some of the programs that I see that are even being more creative aren't just thinking about starting with medical assistants, but there are a lot of people who are working in healthcare, in environmental services, in dietary services, who are there because there's some connection to the mission. Those people could be working in a lot of different places, including Amazon. They're working in healthcare because there's some connection. And so just be really creative and sweeping wide around who you might want to support, I think, is one of the things that I would say. There were a lot of questions about also alternative models of care. And we've talked about a lot of those. I think one thing that we didn't mention so far is this whole idea of self-service. One of the ways of unloading care from the healthcare system is to move more towards self-service. When I go to the airport now, I check myself in. I even tag my own bag. I mean, tomorrow I might be flying the plane. I don't know, but no, I'm joking. But they clearly have pulled away every little thing that can be done, and yet in healthcare we still put so much of the burden on providers. I mean, even to the point of if someone wants to administer their own insulin, we make the nurse administer the insulin. I mean, there are things that we do that don't make any sense anymore in today's day and age. My husband recently had a minor outpatient surgical procedure, and the nurse called him and walked him through the questions for his pre-op check-in, rather than sending him a form and having him fill it out. So there are lots of places like that. I was just talking with a nurse executive last week, and one of the things that their team is doing is that on a weekly basis, they are walking through some part of the system from the patient perspective, even things like driving up and seeing what parking looks like. So, I don't know that it always has to be the executive team, but once again, systematically doing things like that can really identify those things that are taking time and attention from your employees.
Right. Yeah. And there's some additional questions that are along those themes. I think that as we begin to wrap on with all of your wisdom and cues you're getting from the marketplace, and of all the ideas of what we can do organizationally as a team and individually, what's your single most important recommendation for what people can do where they are to begin to advocate for a journey that can be transformative for the experience of nurses? What would you say?
The one thing I would say is to start with an honest assessment of how things are today. And here's what I mean by that. I shared the example of Baylor Scott & White bringing in a nurse executive to redesign their recruitment process. And that really came from an aha that their recruitment process was designed when they had about a 7 or 8% vacancy rate. They currently, at the start of this, they had an 18% vacancy rate. So you can't ignore, you can't run your processes the way that you did before. I noticed that someone in the chat mentioned something about scope, span of control for nurse managers. When we were staffing our units with largely full-time nurses to get our 60 FTEs, and you had maybe 75 nurses, and today to get those same 60 FTEs, you're doing it with part-time staff and you have 120 nurses. Your nurse manager's workload has increased significantly, and you can't pretend like it is the same. So I think starting by doing an honest assessment of how things are really, as nurses, we always start with our assessment, and looking at what really has changed and building from there, I think is key.
Right. And some of the other things I've seen and places that are, again, beginning to move the needle is challenging decision makers and capital allocators regarding how will we use investment to care for our people. I think it's, in my mind, a CEO's most important indication for how they're doing is the engagement of their people. Yeah. And some could even say that is the singular most important thing that allows all other quality, safety, patient experience, finance, growth to manifest, is the people are engaged. They're going to stay. They will advocate for the place. They will access their discretion or effort. They will use their voice to influence others to move towards their organizational goals, and the experience where they are is everything they hoped it to be.
Yeah.
You get a population like that, and there's no stopping it.
Yeah. And, I think, along those lines, I see a lot of people very wisely investing heavily in onboarding new grad nurses and being very, once again, some real creativity around that. And that's dealing with the urgent issue. At the same time, I don't see the same investment of time and energy going on around how are we going to keep these nurses engaged when they hit year 2? What's going to happen around that 18-month
Right.
mark? How are we going to reinvest in them in their next level of growth and development and maturation and support? And I think if people could start thinking about that today and be prepared with that package. We've talked a lot today about the pivotal role of the nurse manager, that frontline nurse leader. And once again, I just would say, if I would invest anywhere, it would be really investing in that role, because if we can get them strong, comfortable, confident in their role, that manifests throughout the whole team that they're leading.
Well, Marla, thank you so much for your advocacy, your voice, your mentorship of me and so many others. It's so rational and pragmatic, and I greatly appreciate what you've done for the industry and what you've done. And as we talk about this clinical life, my only words of encouragement is this profession, this healing profession, is such an honor. It is such a privilege. We can make such a profound difference for those that we serve. And sometimes we have to remember that those opportunities, despite the burden of all the tornado around us, when we walk into an exam room or meet with a colleague, we still have an opportunity to be a force for good.
Yeah.
And nobody can take that away.
Yeah.
And
I think
fierce advocates for you.
Yeah, and I think there's something always beautiful about the end of the year. I just would encourage everybody to stop and reflect on what all they have accomplished over the course of this last year, because when you're in the middle of it and you feel like you're slogging uphill through mud, it's hard to look back and see the progress that you've made. And we have made substantive and really significant progress. And that is something to be acknowledged and celebrated.
It is. And on that note, as we close, I would encourage you, if you have a moment when you're with your nurse colleagues, if anybody's ever together in a room at one time, is to challenge your nurse colleagues to say, tell me about the best nurse moment, the best moment you've had as a nurse with a patient. And allow people to tell their story. And within about 2 or 3 people, with some tears shed, people will remember that's why we're doing this. Yeah. And despite all the camouflage of all the distraction, the essence of impact and meaning and purpose still resides. Yeah. So again, thank you, Marla. I'm going to share one last thing with the group. We have I had written a new ebook called Building a Coaching Culture that you're welcome to have. It's about how do we build a continuously improving place that allows people to thrive. And you're welcome to have that. And it's about building mastery to fuel human contentment for patients receiving care and those providing it. So with that, thank you all. Keep your heads up, look out for each other, and we'll see you next month on the next This Clinical Life. And we're out.
Bye, everybody.